TGF-beta in promoting glioblastoma growth and immune evasion. Microglia and tumor-associated macrophages, also known as TAMs, are key players in shaping the immunosuppressive tumor microenvironment as well. At the bottom, I made a short timeline of major findings in this area of research. So what I can do with this timeline is I can now identify the gaps in research that, based on what these major findings have found, I can see what still needs to be discovered in this area of research. So what I found is that there are limited clinical success in translating immunotherapies, and there's an incomplete understanding of immune cell interactions in the tumor microenvironment. And then a relevant theory to my research would be cancer immunoediting and chronic inflammation are key frameworks in understanding how glioblastoma evades immune system. Next, I have my methodology and results. So what I did is I reviewed 30 plus articles and clinical trials from reputable sources like PubMed, Google Scholar, and clinicaltrials.org. These articles range from 2011 to 2024. I focus on inflammatory pathways, immune cells, and glioblastoma progression, and I included both retrospective and prospective clinical studies to get the full overview. On the bottom right, you'll see just a short general summary of some of the clinical trials I reviewed, and I'll get more into that in a bit. So some of the results and key findings I found were that cytokines like IL-6, TNF alpha, and TGF-beta drive tumor growth and immune evasion. Microglia and TAMs maintain an immunosuppressive environment, and that a combination of therapies show promise but still remain limited in clinical impact, since it's been pretty new and there hasn't been many clinical trials that show lots of improvement. And the most significant insight that I found is that targeting inflammation alongside immune suppression may improve outcomes, but tumor resistance still remains a very big challenge. All right, so on the top left, I'm just gonna take, for example, IL-6, also known as interleukin-6, and its effect in glioblastoma is that it promotes growth and resistance. So it resists treatment and it helps the tumor grow. And the clinical relevance is that there are trials ongoing with IL-6 inhibitors that's happening right now. So what this would do is it blocks IL-6 from doing its job and helping promoting the tumor from growing. Also, an example of one of the clinical trials I reviewed, it would be the Gloria trial, and the therapy that was studied in that would be NOX-A12 and radiotherapy. So NOX-A12 is basically an inhibitor for the CXC12 pathway, and that pathway helps the tumor grow. So by inhibiting that pathway, it stops it and the tumor won't grow as much. So an outcome of this trial would be improved disease control through immune remodeling in recurrent glioblastoma. All right, so my conclusion. To recap, my recent question is how do inflammatory pathways and immune responses contribute to glioblastoma progression and resistance? A summary of my results would be chronic inflammation and immune suppression and how they play central roles in glioblastoma pathogenesis. Cytokines like IL-6, TGF-beta, and immune cells like TAMs and microglia enable immune evasion, and clinical trials targeting these mechanisms show early but limited success. So what I've done in my contribution to this research is that I've conducted a focused literature review of 30 plus studies and trials from 2011 to 2024. I've identified gaps in understanding of immune tumor interactions and evaluated emerging therapies. And I synthesized my findings to highlight promising combination strategies for future research. So while I was researching, I did come across a couple of limitations. So one would be that I'm limited to published data. I'm only limited to what I can find online. I didn't directly collect evidence. I didn't conduct any experiments. I was only limited to what I could find published online. Also, another limitation would be inconsistent trial designs and patient cohorts, making comparisons challenging. So it's hard to compare how effective one treatment is compared to another, and that many therapies are still in early stage trials with no long-term outcome data. So a lot of clinical trials that I've reviewed happened recently, and they're still ongoing. So it's hard to collect accurate data with only a small group of people, and it's still ongoing. So as time continues, it might get better. All right, so I just wanted to say thank you to everyone. Thank you, Dr. Prahlad, for instructing me and educating me on this topic. I haven't learned about this before, but after his instruction, I've learned a lot more. I also want to thank Professor K for guiding me through this process because I've this is my first research paper, and she's helped me learn how to write one. And I'd also like to thank Joe and Gifted Gabber for really organizing this program for students like me. And yeah, I just want to thank everyone else.
Yeah, you can stop sharing your screen. I'm going to have Professor Prahlad ask a question. Great job. Very proud of you. Extremely good presentation. Yes, Dr. Prahlad.
Hey, Yuan, yeah, great
Hi,
job.
thank you.
Congratulations. Yeah. So, in your findings, so what's the future? Like, do you find any, you mentioned that IS-16, there are some pathways are important. So, is there any clinical study going on to target those pathways? Did you find anything?
Yeah, so there all are a couple of clinical trials and studies that are still ongoing. Like I said, there most of them are still ongoing, but there
Mhm.
are clinical studies that are testing inhibitors and pathway inhibitors. Like I mentioned, um, that inhibitor that affected CXCL1 2 that
Mm-hmm.
really stopped the growth of the tumors. So there are ongoing studies, and with more time, you can get more accurate results with it.
Okay, great job. Yeah, say CXCL12. Okay,
Yeah,
not 1, 2. Okay. All right, good job.
thank you.
Congratulations.
Yeah. So thank you, Yuvan.
Mhm.
Thank you for presenting. And two questions for Yuvan on the chat, please. Your performance and your recommendation is based on the kind of questions that you will ask. And hold on, we have Professor K. So I'm going to have Professor K ask you a question, please. Professor K, thank you for your contribution. Thank you, Dr. Prahalad. I want to thank both of them for really mentoring kids, and Professor Prahalad for simplifying and teaching high school students about cancer. So thank you very much. A question for
Great.
you and Professor K.
Hi, good morning. It's 4:30 in the morning here. Okay, for you, Van, you mentioned that you met several limitations and it's one of your frustrations, right? Um, but what certain data would you have wanted to have been included in your original research that you were frustrated not to be included in your current presentation?
Right. So clinical trials was a main part, so you can see how effective these treatments actually are. So these treatments, when they affect the immune system and inflammation, you can see the success rate when with these clinical trials. But the problem was it was very difficult finding clinical trials just for this topic because this topic is pretty specific. Not many people are conducting clinical trials so on this area. So if I had access to clinical trials that were actually directed toward this and actually had treatments that directly affected the immune system and inflammation and how that would affect the tumor. So if I had access to that, that would have been much better. But I've still found some trials, and most of them are ongoing. So maybe once those trials finish, I could get more accurate data.
Yeah, great job. I mean, I have to remind everybody that it's a high school student who's presenting and talking about cancer, which is pretty amazing. Next up, we have Dhanya. Thank you, Yuvan. All the very best.
Thank you.
Yeah. Yeah. Dhanya, can you hear me? Yeah,
Yeah,
let
I
me
can.
just, yes.
Should I share?
Welcome, Dhanya.
Yeah.
Yes, go ahead, honey.
Okay, got it. I don't know. Can you see my screen?
Yes, why is it so small?
Oh,
You're like a vertical, it's just, yeah, okay.
let me try again. I'm not really sure.
Or, honey, if you can give me your presentation, I can present and you can
Okay.
talk. I can also
Perfect.
have it. Give,
Yeah.
yeah, give access to that, however it is, and I'll present.
Okay. I put it in the chat.
Okay, I'm just going to open it.
Okay.
Yeah, I have it here. I'm going to share. Hold on 1 second. Yeah, go ahead.
Okay, perfect. Good morning, everyone. My name is Danyashri Ananta Prakash, and I'm studying in California high school as a junior. I'm so excited to be presenting my research with you. I'm presenting one of the most challenging and aggressive types of breast cancer, which is triple negative breast cancer, or TNBC. Today, I'm going to be going over, sorry. Today, I'm going to be going over how cancer stem cells play a powerful role in why this cancer keeps coming back and relapsing even after the treatment. But before that, most importantly, I want to be talking about how the strategies that scientists are using to outsmart this resistance, and from immune therapies to epigenetic genetic drugs and next generation antibody drug conjugates. This project has been really eye-opening for me, and I really thank Gifted Gabber and both of my professors for leading me through this project. Breast cancer is not the only most frequently diagnosed malignancy in women worldwide, but also a disease that's defined by its molecular complexity. According to the World Health Organization, actually over 2.3 million cases are reported annually with over 685,000 deaths, and it's a leading contributor of global cancer-related mortality. So it's the most common cancer worldwide, and like I mentioned, over 2.3 million new cases a year, and there are three different subtypes that are most essential to triple-negative breast cancer. So HR plus is when the cancer itself has both progesterone and estrogen receptors. And there's also another receptor that is essential, which is the HER2 plus receptor, which is essential to combat cancer. But in triple negative breast cancer, since none of these receptors are available, it's really hard to be able to defeat this type of cancer with chemotherapy, as there is no receptor for the chemotherapy to bind to and kill off these cells. Hence the name triple negative breast cancer. Breast cancer is the most common cancer globally, and there's multiple subtypes, like I mentioned. HER2 plus produces too much of the HER2 protein. HER2 plus produces too much of the HER2 protein, which promotes really fast cell growth. HR has receptors for estrogen and progesterone, which fuel the cancer's growth, which is easier to deal with and treat because of the presence of the receptors. However, triple negative breast cancer lacks estrogen, progesterone, and HER2 plus two receptors. So that's why it's called triple negative, because it's unable to be treated because of those. Yeah, next slide. So this is data from the World Health Organization, and it's a map of the global female breast cancer burden patterns in 2022, and the estimated incidence and death rates per 100,000 women in 185 countries. So the map shows regional incidence and death differences, and it demarcates between higher and lower rates of the deaths and estimated incidences. Next slide. So why does chemotherapy fail in triple negative breast cancer? So initial sensitivity does not lead to the long-term remission because there's a high relapse. Actually, 40% of relapse occurs within the first 5 years, and chemotherapy targets dividing cells. But in this case, cancer stem cells are not being able to be targeted because of the triple negative breast cancer qualities that it does not have the necessary receptors to defeat these stem cells. The cancer stem cells survive, therefore, and this is what leads to the reoccurrence, metastasis, and resistance. So I conducted a literature review, and this is the main literature review articles that I felt were most important to my articles. So this is on cancer stem cells and chemoresistance. So cancer stem cells can cause relapse and resistance, and I grabbed this from all the citations that I've mentioned there before, and I've also got data for clinical trials that target cancer stem cells as well. Next slide. So I used peer-reviewed studies from 2013 to 2024 from PubMed, NIH, and clinicaltrials.gov. So this included preclinical, transitional, and clinical trial sets, and we focus on cancer stem cells and relapse, resistance, and metastasis. So the keywords that I searched up in clinicaltrials.gov specifically is triple-negative breast cancer, cancer stem cells, TNBC, chemo resistance, and cancer stem cells, CD44 ALDH breast cancer, not signaling triple negative breast cancer, epigenetic therapy, which is a new therapy that is being used to target triple negative breast cancer because of their lack of receptors, and more. Okay, so key results from this literature review is over 40% of triple negative breast cancer patients relapse within first 5 years, and cancer stem cells express both CD44 and CD24 in 70% of residual triple negative breast cancer tumors post chemotherapy. And there's immune activation through entinostat and nivolumab, which is both a therapy that is used, and it's a new type of therapy that is used to target triple negative breast cancer by using these two drugs that can easily help use immune activation to target these instead of the presence or absence of these receptors. And down below, I have more drugs that are being used in the future so far. So my research centers on this intersection, and it investigates how cancer stem cells enable therapeutic resistance in triple negative breast cancer, and how emerging targeting strategies can overcome this resistance and fundamentally change the clinical trajectory for patients.
Yeah, your presentation is done, right? You want to speak about your experience?
Yeah. For me personally, I started this project very late on, and I felt that I was behind all of the students. Thankfully, thanks to both the professors, I was able to catch up and finish and work on both my research paper and the presentation while getting a wholesome experience of the whole research. I want to thank Dr. Prahlad and also Professor K for helping me navigate through this research paper on such limited time and giving me the right experience to kind of go through what a real literature review and research paper looks like.
Wonderful. Thank you, Danya. Very nice presentation. Professor Prahlad, a question for her.
Yeah, Danya, great job. Yeah, you really did tremendous job in a short time. So that's awesome. Okay, congratulations. So in your thing, so I'm asking about clinical trials. So did you find anything that specifically target the cancer stem cells? Any therapy in your review?
So recently, there's been a study where they've been trying to bioengineer cancer stem cells to behave differently, to be able to target them in triple negative breast cancer without the receptors. And they've been I have to look into the exact details, but there's been a study where they've been kind of bioengineering them separately to kind of be able to target triple negative breast cancer.
Okay, that's cool. Yeah, I would like to see that in your paper then. Okay,
Yeah.
great job.
Excellent.
Congratulations.
Yeah. Excellent. A question from Professor K. Professor K, a question for her.
Yeah, moving forward, if you're going to conduct a study on this, how would you wish to conduct a study on this to improve this study?
I think this research was heavily literature review focused, but in the future, if I could, I would like to be hands-on and maybe see how I could maybe work with the cancer stem cells myself. Like I mentioned, the current study about bioengineering cancer stem cells, maybe possibly if I could try to do something like that to directly impact triple negative breast cancer. But this was a really kind of overview of the clinical trials that are currently going on.
Okay,
Excellent.
congratulations.
Yeah, a big round of applause to Dhanya, a virtual applause, of course. Wonderful. And everybody, please be more encouraging and ask 2 questions for Dhanya and Yuvan so far. Let's go with Shubh Patel. Shubh Patel, you want to come on?
Can you see me?
Yes, I pinned you. Yes, go ahead.
Um, okay. So this is my research. First I want to thank you guys for joining me. My name is Shubh Patel. I'm going to be presenting my research on plasma-based mRNA for early detection of large cell lung cancer. So large cell lung cancer remains one of the deadliest cancers worldwide, with LCLC, which is large cell lung cancer, compromising 10 to 15% of cases. Um, Due to its aggressive behavior and vague early symptoms, early detection is very hard and difficult to find, limiting treatment success. And then recent advances in liquid biopsy, especially plasma-based microRNA profiling, offer a promising, minimally invasive approach to identify LCLC at early stages, potentially transforming patient outcomes. Okay. Um, so understanding the large cell lung cancer. So LCLC is a subtype of non-small cell lung cancer featuring large, poorly differentiated cells that proliferate rapidly and can arise anywhere in the lungs. Genetic alterations. Key mutations include TP53, STK11, LKB1, and KEAP1, impacting cell growth, metabolism, and oxidative stress responses. Um, so clinical challenges, early symptoms are nonspecific, such as chronic cough or fatigue, making early diagnosis difficult and contributing to poor survival rates. Um, so my study employs a qualitative review based on methodology, focusing on evaluating the role of liquid biopsy, particularly plasma-based mRNA classifiers, and early detection of LCLC. So I analyzed clinical trials and reviews to assess current knowledge on LCLC, liquid biopsy methods, and circulating biomarkers. So limitations of existing detection methods, um, low dose computed tomography, LDCT, is like the predominant screening tool for lung cancer, but has limited sensitivity in detecting early stage LCLC due to subtle tumor appearance and peripheral tumor locations. It also carries risk of radiation exposure and false positives. Chest radiography and sputum cytology. These conventional methods lack sufficient efficiency to reduce mortality in lung cancer screening and struggle with early detection of LCLC, leading to their declining use. So emerging screening technologies. Um, so right now there's circulating tumor DNA, ctDNA, which detects tumor mutations in blood, enabling genetic profiling tumors non-invasively and potentially detecting early cancer stages. And then there's exhaled breath analysis, EBA, which analyzes volatile organic compounds in breath, providing a radiation-free, non-invasive screening option for lung cancer. It also is a lot cheaper, so it's better for patients that typically don't have much money. microRNA, mRNA profiling. Um, It leverages plasma mRNA signatures associated with lung cancer pathways to identify and differentiate LCLC earlier and more accurately. So, liquid biopsy, revolutionizing diagnosis. So, historically, screening methods like chest radiography, CXR, and sputum cytology were used to show limited efficiency in reducing mortality rates. Um, LDCT has become the standard for lung cancer screening. Um, which however it has like limitations, includes high false positive rates and radiation exposure. So in this, it's number one is minimally invasive blood-based assays, avoid tissue biopsy, reducing patient risk and discomfort. Number two is real-time monitoring, allows tracking of tumor dynamics and treatment response over time. And three is molecular precision, detecting genetic and epigenetic changes specific to LCLC for accurate diagnosis. Okay. MicroRNAs as biomarkers for LCLC. So miRNAs play critical roles in regulating gene expression and have been linked to tumor development and progression. And LCLC specific miRNAs, like MIR21, MIR 115, and MIR 210 are frequently upregulated, influencing pathways related to apoptosis, proliferation, and angiogenesis. Plasma-based mRNA profiling offers um, a non-invasive diagnostic tool, potentially enabling early detection and classification of LCLC. So, a ongoing clinical trial is exploring the use of plasma-derived mRNA profiles to detect early stage lung cancer, including LCLC. This study combines next generation RNA sequencing with machine learning to identify mRNA classifiers capable of distinguishing lung cancer from uh, from beginning conditions with high specificity and sensitivity. Okay. Um, Artificial intelligence enhancing detection. So first is image analysis. AI algorithms increase accuracy of LDCT by detecting subtle tumor features, improving early LCLC diagnosis. And then number two is biomarker integration, combining molecular data like miRNA profiles with imaging to enhance predictive power. And then three is personalized prognosis, predicts patient outcomes and therapy responses based on genetic and clinical data integration. So challenges and future perspectives. Number one is validation needs. Standardization of liquid biopsy assays across populations is critical for clinical adoption. Number two is technical limitations. Ensuring sensitivity and specificity while managing false positives remains challenging. Number three is clinical implementation. Integrating liquid biopsy with existing imaging and clinical workflows requires multidisciplinary effort. Number four is patient impact. Improved early detection could substantially increase survival and reduce mortality for LCLC patients. So, in summary, LCLC is an aggressive, often late diagnosed subtype of lung cancer. Um, Traditional diagnostic methods struggle with early detection, highlighting the need for innovative approaches. Advancements in liquid biopsy research, especially into miRNA biomarkers, hold promise for revolutionizing early detection and treatment for LCLC. Continued research is essential to validate and standardize these biomarkers. Uh, with the potential to significantly reduce LCLC related mortality and transform lung cancer care. And that's all.
Yeah, you want to stop sharing your screen and share your experience?
So I'd like to thank Dr. Prahlad and Professor K for helping me. Dr. Prahlad actually helped me find a few like these articles, which really helped me a lot. And Professor K actually like stayed up with me to help me create this presentation. So I'd like to thank them a lot for helping me.
Yeah, a question from Dr. Prahlad.
Oh, yeah, great job, Sue. Great presentation. And so you mentioned miRNA. So circulating tumor DNA detection has been around circulating tumor cells, right?
Yeah.
How is miRNA better? Why do you think it's better then? Or why did you pick miRNA?
So, great question. So, um, circulating tumor DNAs and circulating tumor cells have indeed been established as biomarkers in liquid biopsy. Uh, However, microRNAs offer several advantages that make them promising for early detection. They have like higher stability, um, uh, which uh, which makes them less prone to like degradation than ctDNA or RNA from CTCs, especially in plasma samples. Um, they have a higher early detection potential because they can mRNA expression changes can occur very early in tumor development, sometimes before detectable DNA mutations appear in ctDNA. So that means like mRNAs are like able to like catch cancer at an earlier stage.
Okay, thank you.
Yeah, a question from Professor K. Yeah.
I actually had almost similar question with Dr. Prod, but yeah, move forward. How would you want to conduct this study?
Could you say that again?
Yeah. Moving forward, what would be your next steps as a question? She's breaking up.
So, moving forward, my focus on clinical validation would be on clinical validation and implementation. So, I'd like look at larger clinical trials,